the stroke. So there's two types of strokes. There's ischemic stroke and there's hemorrhagic stroke. So let's talk about ischemic stroke first. Ischemic stroke occurs 85% of strokes, and that can be because of a thrombus or embolus, and because of hypoperfusion, so like a hypotensive state. And then so what is the difference between a thrombus and an embolus? So a thrombus is like it's like within like that let's say it's in the cerebral artery. It's a clot within the cerebral artery that's formed. And then versus an embolus, that's like when let's say you have AFib or something, and then that clot travels, and then it goes to like block one of the arteries to the brain, and that's what an embolus is. And then the most common like embolus for like an embolic stroke occurs from the left atrium because of AFib. So some risk factors for ischemic stroke would be related to atherosclerosis. So some of the things would be like diabetes or increased cholesterol, high blood pressure, bad diet, and advanced age. And then some consequences of stroke that would include cell death. So that's called a core. That's when your brain dies. And then penumbra. So the brain cells are like suffering. They're like around that area that's infected with the death. But it's still alive, but like it's barely alive. It's gonna die if you don't do anything. So what we need to do is have a perfusion therapy, so like TPA, and then we can give this within a 4.5 hour time. So time is essential for strokes. So one of the questions is, why does hormone replacement or contraceptives increase stroke risk? That's because estrogens increase risk for blood clots. And then there are many different types of names for stroke. So lacunar stroke. So that's when there's a narrowing of small penetrating arteries that supply blood to deep brain tissues. So to like the basal nuclei or brainstem. And the cause is usually because of hypertension or diabetes. And then we have the watershed stroke. So blood flow is blocked at the border zones between two major arteries in the brain. So like this. And then for this one, the lacunar, it's like when there's like a little, just like small arteries, like they're like narrowed, not enough blood, right? And then for transient ischemic attacks, so those are just like a temporary stroke. So you will have like the same symptoms as a stroke temporarily, and it usually resolves within 24 hours. But with TIAs, it increases the risk for strokes. So it's very likely that you will have a stroke again. So that's why we give like platelets, antiplatelets and stuff. Medication to prevent the strokes. So next type of stroke we're going to talk about is hemorrhagic stroke. So that occurs 15% of the time. So this is when the blood vessels weaken and rupture. So there are two types. So there's intracerebral and subarachnoid. So with intracerebral, so it's inside the brain, right? So if there's a bleeding within the brain, the leak blood causes injury and decreases the blood flow, and it compresses the surrounding tissue, so it increases the intracranial pressure. And then with subarachnoid, it bleeds into the subarachnoid space surrounding the brain and spinal cord, and then mixes with the cerebrospinal fluid. So that also increases like the pressures and stuff. With this one, intracerebral, I think it's worse because like it really the brain can't really do much to compromise for it. It's just gonna keep increasing that pressure. Versus with the subarachnoid, like it'll try to move like the fluid into different spaces. So after bleeding stops, it forms a hematoma, also known as a clot. So what are the main causes for hemorrhagic stroke? So a big one is hypertension, and then some other ones would include like a ruptured aneurysm, arteriovenous malformation. So that's like a congenital malformation where it forms like a tangle, like a capillary thing, and then it can enlarge and rupture if there's like more blood pressure and stuff. And also like weakening of blood vessel walls, so like the weakening of those, brain tumors, and blood clotting deficiencies. So one of the most common like anterior cerebral artery aneurysms is the Berry aneurysm. So that's like 95% of cerebral aneurysms, and that affects vessels of the cerebral arterial circle. So what happens is it ruptures, and then that would lead to a subarachnoid hemorrhage. So what we have to think about is hypertension is the biggest risk factor for hemorrhagic stroke. And then treatment for hemorrhagic stroke is like to stop the bleeding and maybe like having a surgery to decrease the intracranial pressure. So like maybe like just like a burr hole or something. So what influences the severity of the stroke? So comorbidities, medications, delayed time to get help for a stroke, the type of stroke, and the location. These all influence the severity. Some assessments that we can do would be a focused neuro assessment, especially with like the acronym FAST. So facial droop, arms to see if there's any drift, speech, is it like slurred or not slurred, and time. We need to know about the time so that we know like we can treat it, like if we can do TPA or whatever. And then we can assess the Glasgow's Coma scale. So that assesses like the eye-opening, verbal response, and motor, so to see if they can follow commands. And then we can check the pupils, Perla, and we can do this little NIH stroke scale. So if it's like the lower the score, the better. And this tool, it helps look at the severity and helps guide what type of like therapy person's going to get. And it also predicts like the outcomes, like the short-term and long-term outcomes for the patient. And we should always also assess for swallowing, or we can also consult a speech language pathologist, because like they might have dysphagia. And then we should always try to ambulate them early, so early mobilization. So like having them to sit up, stand, and then we should also do glucose checks, because if there's a brain injury, like your brain is using a lot of metabolism to like help heal. So that's going to take a lot of glucose, and that can make you go like hypoglycemic. So that's why it's important to check, because glucose is like one of the things that supplies the brain with energy. And it's also important to reposition the clients maybe like every 2 hours or so. Just promotes like comfort and prevents like pressure sores and stuff. And also with blood pressure management, so we have to monitor that. So we have to monitor the MAP. So that's this just determines like if we're getting perfusion, adequate perfusion. So if it's above 60, then that's good. And then in terms of like blood pressure management for hemorrhagic, we might want to decrease the blood pressure so that and like elevate the head of bed up a little so that we don't increase the intracranial pressure. And for ischemic, we want to make sure like the blood pressure is like it's like optimal. Like you're still getting like the blood supply to the brain. We don't want it to go too low. So some tests that we can do for strokes. So initially, it's very important that the patient gets a CT immediately to see whether it's an ischemic or hemorrhagic stroke. And then we can follow up within like maybe 48 hours with a CT or MRI to see if there's any changes. And then we can do an ECG to identify like risk factors such as AFib. And we can also do a carotid ultrasound, which can help identify the source of emboli and the thrombus. So some medications for stroke patients would be, so we have antiplatelets, anticoagulants, and thrombolytics. So antiplatelets, that would include aspirin and clopidogrel. These can increase like the risk for bleeding. They're like a antiplatelet. So basically they help with preventing platelet aggregation, so preventing them from forming a clot, because like platelets like to stick together. And then with anticoagulants, we have warfarin, and we have like medications such as like apixaban, rivaroxaban, dabigatran, yeah, those. So with warfarin, it basically prevents like the synthesis of vitamin K. So vitamin K is like a vitamin that helps with clotting. And from what I've learned, warfarin is not like the recommended one, because it's like more risky and you have to do more blood work and stuff. However, it's good for like if people have like a mechanical heart valve like issue. And then with the other stuff like apixaban and all these Zabans, from the studies, it's been shown to have like a better effect, and it's safer. And then it also requires less like blood work, like less checks of blood works. And they also say that it's good for like AFib and TIAs like compared to antiplatelets. So this one is highly recommended. And then finally we have the thrombolytics. So that would be the TPA, so also known as tissue plasminogen activator. The name is Adapalase, and this basically helps break up the clots. But this is a very high risk medication, usually used in critical care, and it's time sensitive and has a strict criteria, and it can increase the risk for bleeds. So with strokes, it will affect either the left or right side. So some signs and symptoms. So let's start with right-sided stroke. So right-sided stroke, it will lead to left-sided hemiparesis or hemiplegia. So hemiparesis is decrease in like strength, versus hemiplegia is paralysis. And then you will also have left visual field deficit and left-sided neglect, lack of awareness of deficits, and like just lack of spatial awareness. And because of this, you will have like quick, impulsive behaviors. And then on the left side, for the left-sided brain damage, you will have right-sided hemiparesis or hemiplegia, and right visual field deficit, aphasia, so like speech and language problems, awareness of deficits. So this would lead to more anxiety and depression, and because of this, you will have like be slower and more cautious with your behaviors. And for both, you'll just have like weakness, dysphagia, impaired mobility like ataxia, poor planning, organization, and fatigue, memory issues. And I think that's it.